Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Our lecture today will talk about the part 2 of treatment of class 1 malocclusion. So, spacing. In general, spacing can be divided into generalized spacing is due to either hypodontia or small teeth in well-developed arches. Orthodontic treatment of generalized spacing is frequently difficult, as there is usually a tendency for the spaces to reopen unless permanently retained used. In minor cases, it may be useful to encourage the patient to accept the spacing. However, if the teeth are smaller than average, the aesthetics can be improved using acid etch composite additions or porcelain veneers to widen them, as we see in these two pictures, is before and after. While in severe cases of hypodontia, a combined orthodontic and restorative approach may be required to localize a space to provide prosthetics or implants. So in this figure, this patient with hypodontia where the upper right second premolar and all four lateral incisors were absent and generalized spacing. So treated with fixed appliances to localize space for prosthetic replacement. So we have pre-treatment and B showing fixed appliance. The cause for generalized spacing, number one, microdontia. The microdontia, the presence of small teeth in the normal jaws, will result in generalized spacing. Such conditions are best treated by checked crowns, composite build-ups, or consolidation of spaces and placement of bridge. And also you can see these two pictures or three pictures. The second cause is macrognathia. This also manifests in the same way as small teeth, but here the teeth sizes are normal, whereas the arch size is bigger. Best method of treatment is to protract the posterior teeth to close anterior spaces if the profile is acceptable. This eliminates chances for relapse. Other method will be checked crowns, composite build-up, or consolidation of spaces and placement of bridge. Number three, macroglossia. A very large tongue causes generalized spacing, so the lateral border of the tongue show indentations. Treatment is not advisable unless the malocclusion is gross. If malocclusion is gross, partial glossectomy or excision of wedge of tissue from the tongue can be advised. The other causes, sucking habit may also cause generalized spacing. 5. Abnormal tongue posture may also cause generalized spacing. Other type of spacing, localized spacing. It may be due to hypodontia or loss of a tooth as a result of a trauma, or because extraction was indicated due to displacement, morphology, or pathology. Etiology of localized spacing. Number one, missing teeth. A congenital missing teeth. This causes localized spacing. as these two pictures. B. Unerupted teeth impacted or unerupted tooth causes localized spacing. Assess whether the tooth can be brought into normal position. This picture will show an unerupted permanent maxillary left central incisor with a dilacerated root. C. Premature loss of permanent teeth. In this situation, decision has to be made whether to close the space or maintain the space and replace with an implant or bridge. A prolonged retention of a primary teeth. This results in ectopic eruption of permanent successor, and when the primary tooth is exfoliated after ectopic eruption of permanent successor, space results. Sucking habit may cause localized spacing, so habit can cause generalized and localized. Hypodontia. Hypodontia in general is defined as the congenital absence of one or more teeth and can be divided into mild, 1 to 2 teeth missing, moderate, 3 to 5 teeth missing, severe, more than 6 teeth missing. Oligodontia. The most common missing teeth are third molars in approximately 25 to 35% of the population, followed by the second premolars 3%, and then by the upper lateral incisor 2%. Missing teeth are also found more commonly in patients with cleft lip and or palates. So as a general rule, if only one or a few teeth are missing, the absent tooth will be the most distal tooth of any given type. So if a molar tooth is congenitally missing, it's almost always the third molar. If an incisor is missing, it's nearly always the lateral. If a premolar is missing, so it almost always is the second rather than the first. Rarely is a canine the only missing tooth. Hypodontia refer to a lack of 1 to 6 teeth, excluding third molars. Oligodontia refers to a lack of more than 6 teeth, excluded third molars, while anodontia refers to a complete absence of teeth in one or both dentitions. I mean a primary or permanent, or one of them. Okay, so now we talk about the management, how to manage the space. The management of congenital tooth absence will involve either space closure or maintenance or opening of space, followed by prosthetic replacement of missing tooth units. Okay, so we have some example. When the permanent maxillary incisor or mandibular second premolars are congenitally missing, the decision whether to extract the deciduous tooth and use this space for orthodontic treatment. يعني إذا كان عندك مشكلة في مكان ما ممكن تستفاد تسوي extraction وتعالج المشكلة عندك, or opening the space by orthodontic appliances and fixing an implant or any prosthesis in that space, depends on various factors. وممكن نسوي opening للسبيس ونسوي بعدين prosthesis for that space. Another example for maxillary laterals, a good option is to move the maxillary canine mesially, as see with this pictures, and use the canine as a lateral incisor. Moving the canine into the lateral position produces little facial change, okay? But the resultant tooth size discrepancy often does not allow a canine guided occlusion. في هاي الحالة لأنه الفانكشن of the canine is guided occlusion, guide of occlusion. فمن canine نحركه مكان اللاترال راح يفقد هاي الخاصية. Or we can create a space for a future lateral prosthesis or implant. For a congenitally missing premolar, the primary molar either may be maintained or extracted with subsequent placement of a prosthesis or orthodontically closing the space. Maintaining the primary second molar may cause occlusal problem, so due to its larger mesodistal diameter compared to the second premolar. فالمشكلة عندنا هنا reducing the width of second premolar or primary molar is a consideration, but root resorption and subsequent exfoliation may occur. So we can reduce the width of second primary molar, but the other problem is root resorption and exfoliation. Generally, management of spacing can be done by orthodontic or combined orthodontic and prosthodontic treatment. So number one, orthodontic management, early extraction of any deciduous teeth to facilitate forward movement of the first permanent molars in that quadrant. Fixed appliances may be required to complete alignment and correct the axial inclinations. Elimination of habits by habit breaker appliance. Localized spacing can be closed with removable appliances with spring, like this appliance. If there is proclination associated with spacing, Howley's appliances or a Roberts retractor are used for closing of spaces and retraction. So when you have slight proclination of incisor with spacing, we can use this spacing to retract the incisor backward. A condition where spaces are to be closed by protraction of posterior teeth can be achieved only by fixed appliance mechanotherapy. So if you want to close the space and should be move the posterior teeth forward, so it is useful to use a fixed appliance. Retention. Cases treated orthodontically usually required long-term retention. Generally, placement of a bonded retainer post-treatment is advisable in the majority of cases, as we see in these two pictures. Prosthodontic management. Sometimes localized spaces are best treated by giving jacket crowns or composite built up. Okay. Combine orthodontic and prosthodontic management. So if the space is severe, then the space is consolidated by using fixed appliance therapy. In the consolidated space, either an implant is placed or bridge. Also, you can place. Masking procedure, for example, contouring a canine incisally, palatally, and interproximally to to be like a lateral incisor, or acid edge composite additions are required. These should be carried out before or prior to the placement of appliances to facilitate final tooth alignment. Okay. Autotransplantation. Autotransplantation is a possible solution for patients with a congenitally missing tooth or teeth in one area and have crowding in another. Teeth can be transplanted from one position to another in the same mouth with a good prognosis for long-term success. If this is done when the transplanted tooth has approximately 2/3 to 3/4 of its root formed. This means that the decision for the auto transplantation must be made during the mixed dentition. A combination of careful surgical intervention and positioning of the transplant, 3 months of healing, followed by light orthodontic forces to achieve final tooth position and restorative. And restorative treatment to recontour the crown of transplanted tooth can result in long-term functional and aesthetic success. The success rate with this type of treatment is high and predictable. So in this figure, this patient has an unerupted permanent maxillary left central incisor with a dilacerated root. So possibly due to previous maybe trauma. It was determined that it could not be repositioned surgically or moved orthodontically. Figure B, to relieve crowding, so premolar extraction was indicated and the maxillary left first premolar was transplanted to the maxillary left central incisor position and moved after a short healing period. C, root development and healing have continued and indicated a vital tooth. While D, we can see in D the tooth will continue to be recontoured and restored with resin before definite restorative treatment. So disadvantages of autotransplantation: general anesthesia required for procedure, requires skilled surgical technique, transplanted tooth may undergo resorption and or ankylosis. Median diastema. Median diastema is a form of a localized spacing wherein there is space present between two central incisors, as seen with this figure. A diastema is a normal physiological stage in the early mixed dentition when the frenum attachment passes between the upper central incisors to attach to the incisor papilla. In normal development, as the lateral incisors and canines erupt, this gap closes and the frenal attachment migrates labially to the attached mucosa. Spontaneous correction of a childhood diastema is most likely when its width is less than 2 millimeter. So this patient is on the borderline and may need future treatment. Whatever its cause, a diastema greater than 2 millimeter is unlikely to close spontaneously. Okay? However, in rare cases, the frenum attachment appears to prevent the central incisor from moving together. In these cases, flanching of the incisor papilla can be observed if tension is applied to the frenum. And on the radiographic examination, a V-shaped notch of the interdental bone can be seen between the incisors, indicating the attachment of frenum. Management of median diastema. It is important to take a periapical radiograph to exclude the presence of a supernumerary tooth, which if present should be removed before closure of the diastema is undertaken. Management can be subdivided as follows. Before eruption of the permanent canines, intervention is only necessary if the diastema is greater than 3 millimeter and there is a lack of space for the lateral incisor to erupt. Care is required not to cause resorption of the incisor roots against the unerupted canines. هذا قبل the eruption of canines. Okay, with عندنا more than 3 millimeter, we can close it. And there's lack of space for lateral incisor also, but the care should be also required not to cause resorption of the unerupted canines, root of the resorption of the incisor roots against the unerupted canines. After eruption of the permanent canines, space closure is usually straightforward. Fixed appliances are required to achieve uprighting of the incisor after space closure. Prolonged retention is usually necessary as the diastema exhibit a greater tendency to reopen, particularly if there is a familial tendency, so the upper arch is spaced or the initial diastema is greater than 2 millimeter. Okay, so in this case we need a fixed appliance to achieve uprighting of the incisor after space closure, and also prolonged retention is very useful and necessary for the after closing of the diastema, especially when there is if there is a familial tendency or the upper arch is spaced or the initial diastema is greater than 2 millimeter. It may be better to accept a minimal diastema, especially if no other orthodontic treatment is required. While the other choice, if the central incisor are narrow, a restorative solution, for example veneers, can be considered, as we see in this four picture, how to treat the diastema and spacing also in general. If it is thought that the frenum is a contributory factor, then frenectomy should be considered. Opinions differ as to whether this should be done before treatment, during space closure, or following completion of closure of the diastema. In general, bonded palatal retainers are advised subsequent to closure of the diastema. Okay? So generally, يعني midline diastema 2 mm or less, there is no need for treatment. Okay? Before the canines erupt. And the second option is to tip teeth together and retain. لكن بتكون midline diastema more than 2 mm can be treated by bodily movement. So the another malocclusion is transverse discrepancy, which can be seen in class 1 malocclusion. So I will discuss this discrepancy briefly لأنه دكتور قاسم أعتقد تكلم كثيرا عن هذا الموضوع. So a transverse discrepancy between arches result in a crossbite. So anterior crossbite treated by the spring with posterior bite plane, expansion screw with posterior bite plane. So this is for anterior crossbite. Posterior crossbite treated by single tooth, even single tooth, treated by cross elastic, as we see in this picture. While the unilateral crossbite treated as unilateral expansion screw, or by using unilateral expansion screw or functional appliance. Bilateral maxillary expansion can be done to treat crossbite by coffin spring, quad helix appliance, helix screw for rapid maxillary expansion. Vertical discrepancy, also the other malocclusion can be seen with the class 1 malocclusion, and also I will discuss briefly because this subject يعني الموضوع حقيقة راح أشرحه بالتفصيل في محاضرتين مختلفتين، واحدة for deep bite واحدة for open bite. So variation in the vertical dimension can occur in association with any anterior-posterior skeletal relationship. Okay, so open bite, anterior open bite, eliminate habit. First of all, for example, thumb sucking, tongue thrust, mouth breathing. So, if for anterior open bite, we can يعني treat in this case إنه eliminate الhabits like thumb sucking أو tongue thrust أو mouth breathing. This is anterior open bite. While a skeletal open bite, so if it is during mixed dentition, either frontal fall or a chin cup with hypo headgear. Okay. Implement dentition, we can use fixed appliance with both with box elastic. Surgery also in severe cases. Deep bite, intrusion mechanics, use fixed appliance, relative intrusion technique. Relative intrusion technique using functional appliance. Functional appliances used during growth period, okay, cause relatively intrusion. So in this, the lower incisor are prevented from erupting. The posteriors are allowed to erupt. This causes opening of the bite. Okay, or extrusion, use anterior bite plane, both fixed and removable anterior bite plane, causes supra eruption of posterior. When the appliance is given, there should be posterior clearance by 1.5 millimeter. The bite opening by supra eruption of posterior teeth should not encroach or upon the normal freeway space, يعني ما يتجاوز freeway space. Bite opening by extrusion of molars which interferes with normal freeway space will not be stable. ما راح يكون stable لأنه بفعل المسلز. Care should be taken to preserve normal freeway space for stability of orthodontic treatment. Okay, so in this picture we see that A, an increased overbite, B, an anterior bite plane separate the molars, allowing for in C vertical eruption of the molar teeth, so this will reduce the overbite. Now, bimaxillary proclination. So another malocclusion can be seen in patients with the class 1. Bimaxillary proclination is the term used to describe occlusions where both the upper and lower incisors are proclined. Bimaxillary proclination is seen more commonly in some racial groups, for example, Afro-Caribbean. And this needs to be borne in mind during assessment, including cephalometric analysis and treatment planning. So it's more common in Negroes and Caribbeans. Okay. Management is difficult because both upper and lower incisor need to be retroclined to normal occlusion. So retroclination of the lower labial segment will encroach on tongue space and therefore has a high possibility of relapse following removal of appliance. So it is حقيقة is very problem when treated the bimaxillary proclination, because there is a room for tongue and there is a balance area, so maybe there is a problem when we retract of the lower labial segment, because there is a high possibility of relapse after removal of appliance. So for this reason, treatment of bimaxillary proclination should be approached with a caution, and concentration should be given to accepting the incisor relationship. في هاي الحالة you can talk about the patient to accept her condition or his condition because of difficulty of treatment or how to keep the results. If the lips are incompetent but have a good muscle tone and are likely to achieve a lip-to-lip seal, if the incisors are retracted, the chances of a stable result are increased. فإذا عندنا كان incompetent lip و good muscle و incompetent, we can do seal of the incisor by lip to lip. If after the extraction, also I mean after the extraction of the incisor, we have achieved a good lip to lip seal, so we have a good result and stable result. While the bimaxillary proclination is associated with competent lips, like this patient, which are unlikely to retain the corrected incisor position. So it's very problem. So permanent retention is advisable. So if you need to treat these cases, cases with competent lips, 2 marks, Negroes, for example, you can do it, but you should put in your mind that you need to permanent retention after finish your orthodontic treatment. And finally, supernumerary tooth. We talk about supernumerary tooth. Also, we will talk about this problem briefly. There are two types of hyperdontia, namely supernumerary tooth and supplemental tooth. Supplemental tooth look like a normal tooth and usually erupt in the same line as the normal tooth and cause irregularity. So as we see in this two picture, we can see supplemental tooth, two laterals. Sometimes it's difficult to know which one is supernumerary and which one is the normal tooth. So supernumerary teeth are most likely to be seen in the anterior maxilla. So the teeth can be displaced secondary to the presence of a supernumerary tooth or teeth. فممكن يسوي لنا مشكلة. ودائما خلي يكون في بالك انه عندما تلاحظ supernumerary tooth in one arch, especially in the upper arch, مباشرة تاخذ cephalometric analysis لأنه يحتمل أن يوجد another supernumerary may be impacted. فدائما تخلي في بالك عندما تجي supernumerary tooth تاخذ cephalometric تتأكد بأنه لا يوجد بعد supernumerary tooth آخر may be impacted. بعدين تبدي علاجك. So the most common supernumerary tooth occurs in the midline of maxilla and is known as mesiodens. Other sites are premolar, distal to third molars, lateral incisors. The other forms of supernumerary teeth seen in the permanent dentition are conical, tuberculate, and odontoma, complex or compound. So إذن الميزودنس were the most common ودائما احنا نشوفها بالميدل لاين اوف ماكسيلا. لكن ممكن نجد other site مثلا قرب البريمولار or distal to third molar or maybe lateral incisor, and we have another forms of supernumerary teeth, conical, tuberculate, and odontoma. If a supernumerary tooth erupts, it can cause localized crowding or spacing. If it is remain unerupted, like this in these pictures, and the cephalometric also, and the periapical or occlusal view, it can cause impaction or displacement of teeth, or occasionally may become cystic. Okay, so panoramic, occlusal, and periapical radiograph all can reveal a supernumerary tooth. And finally, the management of this condition involves extraction of supernumerary followed by tooth alignment, usually with fixed appliances. Displacement due to supernumeraries have a tendency to relapse, and prolongation is required. And thank you very much for listening. إن شاء الله نلقاكم في الأسبوع القادم. تحياتي.